Hello and welcome to this afternoon session on surgical site infection. I wanted to start my presentation initially with speaking about where we are now with COVID-19 and what was happening before, but it's worth recognising that basically surgical site infections will never go away, and that 1 in 20 patients will acquire one whilst they're in hospital, and to understand that surgical site infection prevention is everybody's responsibility who are working in healthcare. So this slide I put in before my presentation because obviously we're speaking about COVID, but it's to understand that as we were about to go into COVID in March, as a patient safety and quality lead, I was getting very sort of frantic calls from various practitioners working in theatres that really didn't know what to do and where to go, particularly around PPE, standard precautions, and understanding what they needed to do in theatres. Now, it's worth understanding that in theatres before COVID-19, the PPE and the standard precautions were at a level that they needed to be. So you would get in scrub sync about 5 different types of face mask. And I saw particularly different people doing different things with face masks, like they'd wear a purple one because it suited them, or they'd take the plastic cover off that protected their eyes because they didn't like it. So they didn't actually understand the use of each mask. And that was even before we even recognised respiratory protective equipment. So this is something that was basic around all the issues that they were having as we were going into COVID-19. And all that did was highlight the issues that we already had that we weren't very good at. So the question is, has COVID-19 pandemic transformed infection prevention and control? And we know it has, and we've obviously improved all the various issues that we've got in practice. I don't think we're 100%, and it's not often consistent across various organisations, and it is a bit intermittent in some places. So these are the objectives of this session. Basically to come from the association of perioperative practice, where we stand, our standards, our recommendations, is research and evidence-based. It's also to look at the various collaborative working that we do with various different organisations and with our partners in industry, and equally to look at the maintaining of asepsis, the recognising the multidisciplinary team, which is everybody, not just in theatres, but around the theatre department, because we couldn't actually function without them. And then also the patient involvement. This is something that they tend to be homing in on quite a lot now, because the patient needs to be informed in such a way that they understand the processes that's going to happen to them when they're actually going into hospital for a surgical procedure. They need to have a buy-in in order to make sure, and hopefully that they don't get a surgical site infection. So preventing and controlling surgical site infections. It is a challenge for healthcare providers and a concern for patients, and the Association of Perioperative Practice recognises that a multi-organisational collaborative approach is recognised in the prevention of surgical site infections, that it's fundamental to important aspects of perioperative care. Acknowledge that every member of the perioperative team has a responsibility across the surgical care pathway. And through research and evidence-based practice, AFB continues to produce the standards that are recognised across the UK, and also hopefully to improve patient safety and also patient care. So these are the various standards that we're probably all familiar with. AFB have brought out the new standards and recommendations just a few weeks ago, so for 2022, which has been updated. You've got the WHO Health Organisation, which is 2018, and also the NICE guidance that we recognise, which is 125, 2019. All of this guidance is something that we use in practice. We tend to look at the research and the evidence based around all of this, and obviously there's Public Health England and other information out there to support us. But it's looking at all of these, and most of them more or less say the same thing, but getting the best evidence that we can put policies together and protocols within our hospitals and organisations, and to recognise sort of a national practice across the perioperative team. So in the 2018, also the WHO recognised that there were some other issues that they need to look at, and they looked at various different modes and things to do with surgical site infections. They identified gaps in the evidence, and therefore they looked at various different approaches. So they put this multimodal strategy together, and they looked at looking at system changes, training and education, which is key. And monitoring the feedback. Often in theatres we don't get feedback. We don't get to know once the patient has actually got the infection, but we don't know what happens to them. And understanding what goes wrong. And also looking at the global guidance to raise awareness of communication within the workplace. And I think that's one of the worst areas that we have is communication. We then also work collaboratively with One Together, another organisation in using quality resource tools that you can use within your operative practice. Patient warming, you've got skin preparation, and also maintaining asepsis, and there's various different posters and guidance. This is all research and also evidence-based by experts who know exactly what they're talking about regarding surgical site infection. We then move on to a job that I worked on with Monoliki, which was a time to act. I'm not sure whether you're aware of this report, which was brought out in December 2020. Basically, we looked at the current guidance that we have, where we're at, what needed to happen, why are we still getting surgical site infections, what can we do to improve this? And these are all the different areas that we looked at. So it's a responsibility, it's training and education and programs, and it's also looking at establishing collaborative multidisciplinary approach to infection prevention, and also looking at the research and the evidence base, which I've already mentioned previously, and looking at the patient's journey from the moment they are actually listed for a procedure and have all the pre-op investigations done. So looking at all the phases of the intraoperative care. It's again looking at patient engagement and education, and also signposting the patients to information or leaflets or various people that they can speak to about their operations. So AfPP works with all of these sort of organisations, and we also produce evidence to support that. Now, if you want any information about this particular report, you can go to the Monoliki stand, which hopefully can provide you with that. And then the key concerns that came out of this report, and from all of the experts that worked on this, was looking at the surgical site infections, what the significant problems were, and substantial input on patients' healthcare professionals came out. Evidence-based research showed that 60% of surgical site infections are preventable, but infection rates remain high. So we were trying to think of ways of why is it remaining high, what we can do about it. There was a lot of variation in practice, there was different protocols. Even though we've got guidance out there, some were following it, some weren't. Some were mixing it up and not getting it right. And also to be aware that 20% of healthcare associated infections, with 5% of patients undergoing surgical procedures going on to develop a surgical site infection. And that is still far too high, which is why we were working on this. And then equally the cost to the NHS, which I thought was quite staggering. So each patient potentially between £10,000 and £100,000 it's costing the NHS, and that's not even looking at the private or the independent sector. Then you need to think about the theatre environment, so making sure that it's clean on a regular basis, you've got protocols, you've got policies in place. Understanding that you need to reduce the amount of equipment that you have in theatre because it gets very cluttered, and the less equipment in there, the less dust and everything else that you can have in there. Looking at the ventilation systems, making sure they've got correct air exchanges, and also having as like a daily cleaning or damp dusting, which often doesn't happen in many theatres. So instrument management and decontamination. So basically we need to look at the decontamination cycle that needs to be followed and not interrupted. We need to look at also following this policy and making sure that it's in all organisations, or if you go to an external organisation for the processes, that's also managed. And then also to take into account the Health Technical Memorandum, HTMO1, and hopefully work with that because that's the best practice and the guidance that you need to adhere to. So contributing factors to surgical site infections. Obviously there's many of those, all of them up there, which most of us are probably aware of. And I wanted to look at some particular things that were concerning me out of those, which was pre-existing colonisation, which we know we need to do, and decolonise patients. And I remember working back in the early 80s when we used to wash patients in hibi scrub. And then it suddenly stopped around about the 90s. And then suddenly we're back again doing the same thing. So why did we change that? Why have we changed it back? And all of this sort of thing makes you realise that what was the reason for doing that? And then the other thing which I wanted to concentrate on was intraoperative skin preparation. So as a registered scrub nurse, many, many years ago, I was never taught how to prep the patient correctly. And undergoing a degree and various training as a surgical first assistant, I was learning more about the potential of inducing a surgical site infection in a patient by not using the correct technique and the application of skin application. And then equally, roundabout technique, you've got other people that are actually performing it without any training, so that needs to be there. And then also the technique, which I've also alluded to, and to making sure that the people that are working in that environment know exactly what they're doing to actually reduce a surgical site infection. So minimizing the risk requires an integrated multi team approach, which we all need to be involved in. And also the implementation of evidence-based guidance is essential to reduce the incidence of surgical site infection. So best practice to preventing surgical site infection. We do have the WHO surgical checklist. We've got the 5 steps to safer surgery. We've got NATSIPS, which is 2015. And all of these are effective and supporting us within this process of recognising at certain stages when the patient needs to be warmed, you know, whether they need prophylaxis antibiotics or not, and all these various things need to be taken into consideration. One of the things that also concerned me was removal of body hair. And I remember in 2008, when I was doing my surgical first assistant training, we were still using razors. And I was trying to remove the razors out and in bed using the appropriate disposable head devices that we had at the time. I found that really difficult because people in theatre didn't understand the processes, the technique, the research, and the evidence behind what we were doing. I did eventually manage to do that. And even the surgeons were making a concoction of hippie scrub and things and using it on the patients and wet and shaving them, which they weren't actually realising that you actually don't need. If you do have to remove hair, you don't have to remove it right down to the skin because you're scraping the skin and potentially causing a raw area for a surgical site infection. So that was something that was very key. And then the other thing is looking at patient temperature. So how often when patients come to theatre is their temperature checked to make sure that it's not below 36? And do you send them back to the ward and warm them again? And I don't think we're quite there with that, and I still think a lot more work needs to be done on that to support patients. And then regarding that, you need to look at the various other areas, which is the alcohol skin prep. That's another area where there's different techniques, the different products, the different percentages. One of my concerns around that is surgical fires, patients catching fire, which is something we're trying to promote and get people to recognise, but they get different application devices, so when you've got an application, you've got less fluid there, and also it's the technique of how you apply that on the skin. So when you're actually doing it, you need to apply pressure on the skin, slight pressure, so you're actually rubbing the skin, and you're actually removing all those microbes and bacteria away, particularly from the incision site of the patient. So the 3 phases of perioperative care. So we've got the perioperative showering, which is your antimicrobial solutions. You've got decolonisation, which we've mentioned. You've got antibiotic prophylaxis, if required, not always needed. Patient warming, which we've alluded to. And then the environment of theatre, which we've also looked at. Appropriate skin antiseptic and technique. Wound closure, are we going to be using antimicrobial sutures? And the technique and removal of wound dressings, advanced wound dressings, and post-op wound dressings. So avoid the removal of hair from the site of the incision if it's not essential to do so. Use clippers. The major sources of infection are microorganisms on the patient's skin, so removing them that normally colonise the skin encourage a standardised and a more thorough approach to skin preparation. We need to enhance the patient's knowledge, which we keep saying, regarding surgical interventions, so they're informed and they become actively engaged in all aspects of their perioperative care, including discharge, so it might be a surgical journey or a pathway, and use the evidence-based guidance that's there to support us to do this. So asepsis, understanding asepsis in theatre, knowing what that is, knowing the difference between transient flora and resident flora, what's actually going to be only transiently on the patient and what's actually there as part of the normal skin flora of the patient. So hand antisepsis, one of the major things of passing on infection, something we've still not got right. We're still having issues, and we've got so much guidance out there, posters, information, research, evidence-based practice. but there is still intermittent, I would say, education, and equally, it's about making sure that education is managed, so it needs to be managed annually, it needs to be observational audits and checks to make sure that people understand that, make sure it's embedded in practice. All of this supports correct hand antisepsis. Now, I've only put a brief information on here, and there's plenty more information out there for you. And also looking at, when you're looking at this, we looked at putting out some posters which regards to hand rub, because we know also that is something people were doing and we're doing instead of scrubbing for each particular case, particularly when you're not leaving theatre and you're just doing short cases like maryngotomies or quick cases like that. So it's important to understand when and how to use this. We then got the technique, that's just sort of telling you more or less how to do it. Theatre etiquette is one of the big issues that's very important, that obviously has been lacking over the years. And equally, we're finding in practice that the bad practice is creeping in a bit like when you're driving and you pick up bad habits, and people are checking on it and making sure and correcting it. Aseptic standard of healthcare practice that helps prevent transfer of germs to or from an open wound and other susceptible areas on a patient's body needs to be understood. Medical asepsis, which is hand washing, that we need to recognise, and surgical asepsis is for surgical procedures. So this is something that equally, even though we're at an infection prevention conference and we've got so much alcohol hand rub out there, I was trying that much on yesterday, my hands were that dry when I got back, I was having to put cream on my hands. It's forgetting obviously that obviously some of it still stays on your skin as well. So understanding that process. So strategies in place to monitor surgical site infections. So the surgical site infection surveillance programme is not mandated and it only covers certain specialities, particularly orthopaedics. It's voluntary at the moment. As part of the report that we did with Monoliki, we were more or less saying that needs to cover all specialities, but it doesn't. It needs to be mandated. Looking at surgical care bundles, particularly for cardiac and other specialities. Clinical governance structures, making sure that the structures you've got in your particular hospitals are fit for purpose. And establishing a baseline for surgical site infection rates. When I was working, I never knew what they were. Nobody informed me about them in theatre. The only time I knew there was an issue was when a patient got an infection. Using the various things that are there to help us, like the NICE guidance. Standardise the practice, and obviously it's not standardised because it's different in different organisations. And using the journey or the integrated pathway that the patient is on, which may vary depending on what particular surgery they're having done. And promoting work through strong surveillance and surgical site leadership. So principles of draping, this is another area that particularly surgeons don't understand and struggle with. As part of the course I did, I learned how to drape, and I particularly had a surgeon that was using a universal drape, and he was putting the bottom one on first, and then the top, and then the sides. And the actual correct technique, particularly using disposable drapes, is the side first, getting close up to the patient, then the other side, then the bottom, and then the top. So practice, again, is inconsistent, people doing different things, and it's understanding the reason of why you're doing what you're doing. He was doing that particular practice when I was with him, and then when he was in the NHS, it was putting bottom on, top on. And I said, you're doing it wrong, you need to do it this way. And eventually he changed his practice because I could provide the evidence base and the research behind why I was saying what I was saying. So this is why it's important you understand equally that when you've prepped the patient, you can potentially, if you do that incorrectly, induce a surgical site infection. If you put drapes on incorrectly or not in the right place, you can induce a surgical site infection. Once you start to put a drape on, you shouldn't remove it and then put it back again. You should discard it and get a new drape if it's particularly disposable. And I see a lot of people sort of moving it slightly and moving it back again. And also looking at the position of where you place it. And also, if you're doing particular procedures, you've got things like IABAN that we use, which are impregnated, and that's a good thing to put on shortly after you finish the full draping. So manage and maintaining the sterile field. So it's not just about what you're doing when you're setting up and you're setting your sterile field up before the case. It's once you've prepped and draped the patient and you actually maintain it throughout the procedure. And often you find lackadaisical practice where people don't adhere to the sterile field and they're not totally aware of where it ends and where it stops and starts, and they're touching things they shouldn't be doing. One particular thing that I saw in practice was when there was a nurse that got an artery clip and scratched her nose and then passed it on to somebody. I had one nurse wrapping around her arms like this and tying a gown, so she just de-sterilised everything. Somebody else actually putting their arms under their armpits, not understanding your sterile field. So looking at that, if you look at this next diagram, you can see what I'm talking about. So there isn't actually a big area that's actually sterile. All the stuff in red is not sterile. So when you've got things hanging below the table, when you're connecting things to a patient, you've got to be aware that if you start touching them, it's past that level, you then touch it and you're de-sterilising and making a potential risk for the patient. Making sure that when you've got, you're setting up your trolley, that it's only the top of your trolley that is your sterile field. Everything else off that and around the sides of it is not sterile. So in summary, basically, surgical site infections have a profound impact, as we know, on both patients and healthcare organisations. We've already mentioned about cost, and we've not talked about the impact on the lifestyle of the patient, repeated procedures and various other things that have to do if they do get one. Then looking at health professionals, if a patient gets an infection and it's your fault, or it's been, investigated and it's something you did or didn't do. So it's understanding that. Engagement of the patient is important, and that is something that they're trying to push and continue to push regarding empowering them, making them understand it. If a patient doesn't want to know, they don't want to know. You can't force them, but it's understanding that the information is there. And equally, some consultants that I spoke to a couple of years ago, just before COVID struck, he wouldn't actually take on a patient if they weren't actually committed to what the procedure would be, what they had to do once they had surgery to protect themselves. So the important influence of patients is becoming increasingly important, as I've said, and the concept of means to improve patient safety and quality of care. So every patient matters. Encourage engagement and compliance, implement prevention strategies, implement surgical care bundles into clinical practice, encourage patients to adopt an active participatory role in their surgical care. And this was a quote I got from Alexander Fleming, which I thought was quite appropriate for this particular event and for infection control in general. So we knowingly or unknowingly are exposed to and face many challenges in the reduction of microorganisms. In perioperative practice, there are rules and guidance which we have acquired, knowledge and experience. However, these are often broken. So, in the end, the prevention and control of surgical site infection is in all our hands. Thank you.